Welcome back to another explainer. We're taking complex medical data and, turning it into a clear visual masterclass. And today we are tackling what's widely considered one of the most intimidating subjects in critical care, arterial blood gas interpretation, or ABGs. I know, just seeing those scattered numbers on a chart can absolutely make your head spin. But stick with me, because by the end of this explainer, we're going to transform all that confusion into rock-solid, methodical confidence.
Okay, let's just quickly run through today's docket. 1. The ABG master algorithm. 2. Solving simple acid-base cases. 3. Uncovering hidden mixed disorders. 4. Diagnosing complex triple lesions. 5. The chronic respiratory curveball. And finally, 6. Master the blood gas. Section 1. The ABG master algorithm. Systematic deduction. To solve any ABG case accurately every single time, we need a reliable system to ensure absolutely no clues slip through the cracks. So here is the absolute core of it, our 4-step master algorithm. First up, you assess oxygenation, usually by looking at the P/F ratio. Second, you identify the primary disorder by comparing pH directly to CO2. Third, we hunt for hidden mixed lesions using anion and delta gaps. And finally, step 4, we calculate if the physiological compensation is actually appropriate. Fix these specific methods in your brain, and you will literally never miss a step in your interpretation. Now, when you're on step 2, trying to pin down that primary disorder, just remember the rule of direction. It's so incredibly straightforward. If your pH and your CO2 are moving in the exact same direction, like both are up or both are down, it is a metabolic problem. But if they're moving opposite to each other, the culprit is respiratory. Just anchor that simple visual in your mind.
All right, section 2, solving simple acid-base cases, putting the algorithm to the test. It is time to take the training wheels off and look at our first 2 patient files.
Let's dive into case 1. We've got a 63-year-old guy presenting with malaise. His pH is 7.32, which is acidotic, and his CO2 is 24, which is low. Since they're both pointing down, moving in the same direction, right, this signals a primary metabolic acidosis. Now we jump to step 3 and calculate the anion gap. We take his sodium of 137 minus the chloride of 101 and the bicarb of 12. The result? An elevated gap of 22. That gives us a classic high anion gap metabolic acidosis. And this is where Winter's formula comes in beautifully for case 1. This brings us to step 4, checking compensation. The formula expects PaCO2 to equal 1.5 times the bicarb plus 8 with a little wiggle room of plus or minus 2. Doing the math on his bicarb of 12, we'd expect his lungs to blow down the CO2 to somewhere between 24 and 28. And look at his actual CO2, it's exactly 24. The math proves the respiratory system is fully compensating. Now, if we quickly think back to case 2, the 74-year-old woman with severe diarrhea, her gap calculated to just 10. That shows us a normal, non-anion gap metabolic acidosis simply from bicarb being lost to severe gastroenteritis.
Moving right along to section 3, uncovering hidden mixed disorders, digging deeper. Clinical presentations aren't always what they seem on the surface, So let's escalate our detective work to uncover hidden complications that a standard glance would completely miss. Check out case 3. Remember our lady from case 2 with the diarrhea? Well, she was subsequently sedated with a benzodiazepine. And look what happened. Her pH literally plummeted from 7.11 to a highly dangerous 6.88. But notice her CO2. It stayed stuck at 40. With a metabolic acidosis that severe, her lungs should be blowing off CO2 down into the 16 to 20 range. Because her CO2 didn't drop like it was supposed to, it reveals a brand new, combined respiratory acidosis sitting right on top of her metabolic acidosis, all caused by the sedation suppressing her respiratory center.
But case 4. Case 4 is where it gets really interesting. A 23-year-old young man with malaise and vomiting. He has a nearly perfect pH of 7.38, a perfectly normal CO2 of 40, and a normal bicarb of 23. At first glance, you'd probably want to send him right home. So, what sinister pathology could possibly be hiding in these perfectly normal numbers? We have to trust our algorithm and dig deeper.
And the algorithm gives us this totally eye-opening number, 33. This is his corrected bicarb. See, even though his initial numbers looked completely fine, we calculated his anion gap and found it was actually elevated at 22. Then, we calculated his delta gap, which is his anion gap of 22 minus the normal 12, leaving us with 10. Finally, we added that delta gap of 10 back to his baseline bicarb of 23, giving us this massive corrected bicarb of 33.
Because 33 is far above a normal bicarb of 24, this mathematically proves he has an underlying metabolic alkalosis. It turns out, this patient actually had a blood sugar over 500. He was in diabetic ketoacidosis, which caused the high anion gap metabolic acidosis, but his severe vomiting was causing a simultaneous metabolic alkalosis. It's like a physiological tug of war. The two opposing disorders perfectly masked each other in his pH, making him look falsely stable.
Section 4. Diagnosing complex triple lesions, the ultimate test. Let's examine Case 5. We have a 58-year-old heavy smoker admitted to the ICU with severe sepsis and an NG tube actively draining. We're looking at an absolutely devastating pH of 6.8 and a bicarb of just 7. These numbers are immediately screaming severe metabolic acidosis. But as we've learned today, we never, ever stop at our first assumption.
Because when we calculate the anion gap using our standard formula, sodium minus chloride minus bicarb, we get a massive, truly alarming result of 35.
Applying the rest of our algorithm reveals 3 distinct crimes happening simultaneously. Lesion 1. A high anion gap metabolic acidosis from a sepsis, proven by that massive gap of 35. Lesion 2. We calculate the delta gap, add it to his bicarb, and get a corrected bicarb of 30. That's significantly higher than 24, meaning there's an underlying metabolic alkalosis, likely from his NG tube draining out stomach acid. And finally, lesion 3. His actual CO2 is 38. But with a bicarb of 7, Winter's formula predicted his CO2 should be breathing way down between 16 and 20. Because 38 is way higher than the expected compensation, he also has a respiratory acidosis. A hidden triple lesion decoded entirely by just trusting the math.
Section 5. The chronic respiratory curveball, acute versus chronic. Before we wrap up, we absolutely have to decipher the clues differentiating acute versus chronic respiratory conditions. Take a look at Case 6. This is a 64-year-old patient with a history of COPD, presenting with worsening shortness of breath. The pH is 721 and the CO2 is 50. Since the pH is low and the CO2 is high, moving in opposite directions, we immediately know this is a primary respiratory acidosis. But here is the critical clinical question. Is this an acute exacerbation or just their standard chronic COPD baseline? We solved this curveball with the brilliant 1-2-4-5 rule for bicarb compensation. It basically tells us exactly how much the bicarb should change for every 10-point shift in CO2. For acute respiratory acidosis, it goes up by 1. For chronic, it goes up by 4. In our patient's case, their CO2 increased by 10 above the normal 40, but their bicarb only increased by 2, going from 24 up to 26. Since it only bumped up slightly, it closely aligns with the rule of 1. This conclusively proves this is an acute respiratory acidosis exacerbation, not just their chronic baseline. Their kidneys simply haven't had the time to compensate yet.
Section 6. Master the blood gas, elevating patient care. By treating ABG interpretation like a rigorous, mathematical detective investigation, we remove the guesswork entirely. As the source material for today's explainer wisely notes, all the algorithms you will find something stopping you, but just try to fix in your brain the knowledge by specific methods so that you will not forget any step. Look, no single system is 100% flawless in the absolute chaos of medicine, but committing to this strict, structured method ensures you never miss a vital clue hiding right there in the open numbers. Which leaves us with this final, provocative thought. If a perfectly normal-looking blood gas, like the young man we saw back in Case 4, can completely mask dual, life-threatening lesions, how much more clinical truth could you uncover tomorrow simply by trusting the math over your initial assumptions? The numbers never lie. You just have to know how to listen to them. Keep practicing this algorithm, stay curious, and I'll see you in the next explainer.